Assalamu alaikum, it's me Dr. Muhammad Qazafi and you are watching Dr. Muhammad Qazafi Views. And now I want to talk about a very important topic which is definitely regarding the pediatric neurosurgery is getting day by day significant importance. And for that, the topic name is the craniosynostosis, and the craniosynostosis result from the premature closure of one or more suture of the skull, and depending on the number of the sutures involved and the range of the complication, the effect on child neurodevelopmental outcome varies. And this activity review the evaluation and management of craniosynostosis and explains the role of the interprofessional care team is improving the care for patient with this condition. Here I want to mention you that the craniosynostosis is a result of an early fusion of the cranial sutures, and these sutures exist to facilitate the passage of the baby through the birth canal and later on allow the expansion and growth of the brain. When one or more suture close permanently, the suture of the skull becomes altered, and once it's altered, then when one or more suture close permanently and the suture and the structure of the skull become altered, so the growing on the path of the least resistance, or we can say perpendicularly on the, or we can say the perpendicularly to the closest suture, and resulting in an atypical shape skull leading to increased intracranial pressure and having an effect on the respiratory and neurological symptoms as well as the development. This is the very basic picture I took, and I want to mention here, you can appreciate here the early closure of one suture. Here the left coronal suture has been closed, or we can say the affected suture. On the other side, you can see the right coronal suture is still within normal limits, or we can say the unaffected, and you can appreciate the metopic suture, it is also within normal limits, and the sagittal suture also within normal limits. So these findings are suggestive for that when the early closure happened. I am just giving only one example, and you can see the what kind of deformity you could expect or appreciate with this picture. And now we will proceed. As I mentioned before, that the craniosynostosis can classify as simple when involving a single suture and complex when involving the multiple suture. So another popular way to classify them is the syndromic, Apert-Rosen or Pfeffer syndrome, and non-syndromic with a isolated finding. So the prevalence of the craniosynostosis is 1 per 2000 to 1 per 2500 live birth, and it has risen with the time, the predisposing factor being either environmental, maternal smoking, in utero exposure to teratogens, or intrauterine, we can say the constraint, or fetal positioning, or I can say the genetic mutations. So almost 20% of all craniosynostosis are due to genetic causes, and most of these being inherited in an autosomal dominant fashion. And although the new mutation arise in 50% of cases and non-syndromic craniosynostosis occur in 75% of cases, and 25% account for the syndromic craniosynostosis, and the craniosynostosis are as you know that the craniosynostosis, or we can say the craniosynostosis is preferred to the premature closure of the cranial suture, and the skull shape then undergoes characteristic changes depending on which suture close early. So that's why the epidemiology I have just mentioned in front of you. And I want to tell you one thing here which is very important. There is a 33:1, and we can say the predominance and a male predominance with an overall incidence. Yes, so it has risen in time, and predisposing factor being either environmental, such as I mentioned, the maternal smoking, in utero exposure to teratogens, intrauterine constraint, fetal positioning, or we can say the genetic mutation. So almost 20% of all craniosynostosis are due to genetic cause, and most of being inherited in an autosomal dominant fashion. So although new mutation arise in 50% of the cases, and non-syndromic, or we can say the craniosynostosis, occur in 75% of the cases, and 25% account for the syndromic craniosynostosis. So the non-syndromic are the 3 times more than the syndromic, means 3:1 ratio for the syndromic to non-syndromic. So it means, and I mentioned also the male predominance in the female is also 3:1. As I mentioned, as with any other condition, through history or the physical examination are most helpful in determining the diagnosis. And here, so as with any other condition, a thorough history and physical examination are most useful or helpful in determining the diagnosis. So while taking the history, it is vital to know if there is any family history of abnormal head shape in utero exposure to the teratogenic drugs. So the intrauterine restraint or an abnormal fetal position, as well as any complication during pregnancy and any delay milestone, or we can say the physical examination allow the clinician to evaluate whether suture fusion is present, or whether any concomitant future feature would like the craniosynostosis part of the syndrome. And like any congenital anomaly, and we can say the dysmorphic feature, assessing a skull is critical. And looking at it from all direction, and we can say measuring the head circumference to calculate the cephalic index, maximum breadth of the skull multiplied by the we can say the by 100 divided by maximum length of the skull. And the examiner should also note and touch the scalp to feel any sutural ridging, or we can say the prominent vessel over the skull, and examine and measure the fontanelle. So assessing the skull is critical, and looking at it from the all direction and measuring the head circumference to calculate the cephalic index, maximum breadth of the skull multiplied by 100 divided by the maximum length of the skull. So this formula should remember: maximum breadth of the skull multiplied by 100 and then divided by the maximum length of the skull. So the examiner should also note and touch the scalp to feel any sutural ridging, prominent vessel over the skull, or the examine and measure the fontanelle. Besides these, depending on the severity of the condition, the patient might present with other clinical manifestation as consequence of the craniosynostosis, which must be kept in mind and monitored. So therefore, an ophthalmological examination should be done, and if any sign of intracranial pressure are present which will show papilledema, and examine possible airway obstruction and feeding difficulties. A different non-syndromic craniosynostosis are described below. As you know, the scaphocephaly or diclocephaly, it is a premature fusion of the sagittal suture. Yes, so I was mentioning that the scaphocephaly or diclocephaly, which is a premature fusion of the sagittal suture, or you can notice that the premature fusion you can see here. This is the fused sagittal suture, and it is a scaphocephaly. So you can appreciate in this picture. And these patients have a long, narrow shaped head with the higher anteroposterior diameter. So as I mentioned, these patients have a long, narrow shaped head with a higher anterior posterior diameter, and frontal boozing is often present, and you can appreciate in this picture. So here you can appreciate how is the frontal boozing and anterior posterior diameter is higher than the then I can say the lateral diameter or the right and left diameter. So this is called the scaphocephaly or diphocephaly, and in which the premature fusion of the sagittal suture. Anterior plagiocephaly, it is a premature fusion of the coronal suture, but the forehead appear flat on the, we can say, the affected side, and the Herlucum sign, or which we can say the high supraorbital margin seen in the radiograph, and the frontal boozing on the unaffected side, and the nasal deviation toward the normal side. So these are happening in the anterior plagiocephaly. So as I mentioned you, the forehead appear flat on the affected side, and the Herlucin sign, which is the high supraorbital margin seen in the radiograph, and the frontal boozing on the unaffected side, and the nasal deviation toward the normal side. Posterior plagiocephaly, this is a premature fusion of the lambdoid suture and the frontal and occipital boozing, or ipsilateral air moved downward from above the head, look like a strabismus. So this is with the, when you are noticing the patient specifically plagiocephaly, posterior plagiocephaly, and especially in this the lambdoid suture is permanent. Here you may appreciate there is a normal brain, normal skull, and then in comparison beside it the picture of the mild plagiocephaly, and down to the normal this is a moderate plagiocephaly, and on the left bottom you can appreciate the severe plagiocephaly, and this plagiocephaly is mentioning that, or you can realizing that how it behaving or showing their means presence or the shape. And in this you can notice there is the frontal and the occipital boozing with the ipsilateral air moved downward from above the head, look like a trapeze. So the other is I want to, this is the example of the trigonocephaly, premature fusion of the metopic suture. The forehead is narrow and pointed, and the head as a triangular shape viewed from above. And you can see here the hypertelorism, and here you can see the we can say the pointed and the narrow forehead. You can appreciate there is a fused metopic sutures, and this picture is very informative in that regard and telling by themselves thousands of words regarding this presentation. Here you can appreciate the pointed and the narrow frontal boozing, and you can appreciate that we can say there is a hypertelorism, and this is a very, I think, a typical picture of the metopic suture and a permanent closure, or we can say the triganocephaly to understand. So, the different syndrome presenting with the craniosynostosis are described in that fashion, that this different syndromic presentations, like as I mentioned, that it could be the Apert syndrome, it could be the Crozen syndrome, it could be the Pfeiffer syndrome, it could be the Mewing syndrome, or we can say the Kiel blasts. So the Apert syndrome affects coronal suture and presenting with the mid-phase hypoplasia. You can see here, and this is the hypoplasia of the mid-phase associated with the hypertelorism, which is that hypertelorism actually it like that the bulging and the wide set eye. The both eyes are means widely aparted, or you can appreciate in this picture very well. And as you know, there is a beaked nose and underdeveloped jaw that lead to, we can say, the crowded teeth, or we can say the hair when this underdeveloped jaw, and it can lead to the crowded teeth and the syndactyly of the hand and the feet, and the hearing loss, and they can have mild to moderate intellectual disability. And because of this, you can appreciate in this picture, every detail is there. You can see there the white thumb, cleft palate could be flat, or the beaked nose, bulging or the downward slanting eyes, hypertelorism, or we can say the high forehead and the tall pointed head, which is also called acrocephaly. This all are present in the Apert syndrome, and that's why, because there's a lot of things, and a syndactyly of the hand and feet, hearing loss, and the mild to moderate intellectual disability. So when everything is present, that's why we are telling a syndrome, and it is discovered by Apert at all. So that's why a name by Apert syndrome. This is an example I just want to present for the Apert syndrome. One more example for the Apert syndrome. So maybe you can memorize it and you can understand it for yourself. Here you can appreciate the syndactyly in the hands, in feet, and the facial impression are very much clear. And by X-ray also you can see the widening of the thumb, and you can see the two bones in the X-ray rather than one phalanx. It is the two bones inside. So this is causing the widening of the thumb. So this is the Apert syndrome. This is the example of the Crozen syndrome and Crozen effect coronal sagittal, and or we can say the lambdoid suture. and feature mid-face hypoplasia, beaked nose, exophthalmos, hypertelorism, cervical vertebra fusion, and hearing loss. So some can present with the cleft lip or the palate, so they usually have a normal intelligence. In the Crozen affected, Crozen effect, especially the you can appreciate here the coronal, sagittal, and the lambdoid suture, and feature mid-face hypoplasia. That's why the beaking of the nose, and exophthalmos or hypertelorism, or the cervical body fusion and hearing loss. And some can present with the cleft lip, and or we can say the palate, and they usually have a normal intelligence. In Appert, you remember that the coronal suture problem, and in Crozen, the coronal, sagittal, and the lambdoid. All three sutures can be problem and associated with the cervical fusion. This is again an example of the Crozen syndrome. And in this Crozen syndrome, you can appreciate the coronal, sagittal, and the lambdoid suture. And these feature mid-face hypoplasia, beaked nose, exophthalmos, hypertelorism, or cervical vertebra fusion, and hearing loss. So, definitely, I want to show all the syndromes here, but for Crozen, I want to tell you here the Crozens have some genetic mutation, and which is called the fibroblast growth factor or receptor gene affected. And this is a rare congenital syndrome and is marked by the, we can say, the premature fusion of the and a few sutures, as I mentioned, especially the coronal, sagittal, and the lambdoid suture. And in this case, the patients are usually neurologically intact and mentally intact. And the clinical examination, family history, genetic testing, all are definitely is here very much important. And surgical intervention is the correct to treat the malformation, or we can say the multidisciplinary team and the specialist required here. And we will talk about it, but just I want to introduce few syndromes here. And now we are proceeding to the another syndrome, which is called the Pfeffer syndrome. So here, this Pfeffer syndrome is features brachycephaly. Brachycephaly, as I mentioned, it is called the bicoronal suture, premature closure of the bicoronal suture, and it features with the brachycephaly and the hypertelorism, then the maxillary hypoplasia, and you can notice here the broad thumbs, or we can say the grade 2 enlargement, and the syndactyly, or we can say the brachydactyly, and the hearing loss. So it is also significant clinical issues with that patient, and I want to show you here. Yes, so this is the open sutures. You can see the allow room for the brain growth in normal infant, but in Pfeffer syndrome, it's not happening like that. And it happens the brachycephaly, and brachycephaly is called bicoronal suture, bicoronal suture, permanent closure in the early age, and the high forehead. You can appreciate wide set bulging eyes. We can say the hypertelorism, and the beak shaped nose. You can appreciate how this is the beak shaped nose, and the smaller jaw. This photo I deliberately bring in front of you people. You know the very famous singer in North America by the name of Prince, and his wife has been died because of the Pfeffer syndrome. And definitely this is a rare genetic problem, and she was suffering with the Pfeffer syndrome. definitely. So she has a bicoronal suture, brachycephaly, and you can appreciate hypertelorism. The both eyes are well aparted, and maxillary hypoplasia is not very much pronounced in her picture, but she has a broad thumbs, and syndactyly was there. So this is the example of the Munch syndrome affecting the coronal suture unilaterally or bilaterally, and features mid-face hypoplasia, hypertelorism, macrocephaly, and hearing loss also. So this is a Munch syndrome. This is the example of the Munch syndrome. Here you can appreciate, and affecting the coronal suture, unilateral or bilateral, features mid-face hypoplasia and hypertelorism and macrocephaly and hearing loss. One more example I want to put from syndromic craniosynostosis, then we will proceed for other. This syndrome actually is called the keel blashadel syndrome, or we can say the clover leaf deformity, or the synostosis of the coronal and the lambdoid suture, and producing a trilobular shaped head, and featuring like a beak shaped nose, maxillary hypoplasia with proptosis, air displays inferiorly, and this craniosynostosis is associated with the hydrocephalus. And this is the radiographic picture which is showing you the CT scan, and how you can see the trilobar. Why I told trilobar? Because you can see the brain is a trilobar. The two lobes on the side and one lobe is separated from, and temporal lobes are little separated, but actually it is not like that, and should not be like that. And I want to mention, this is the example for this keel blashadel syndrome, or we can say the clover leaf deformity, or the synostosis of the coronal and the lambdoid suture, producing at the trilobar shaped head. And you can appreciate this is the keel blashadel syndrome. Regarding the evaluation, although you know the diagnosis is clinically, or you can say the diagnosis is clinical, and many professionals will require the radiological imaging to evaluate further and confirm the diagnosis. The most accurate method is the CT scan, and with 3D reconstruction here all sutures are accessible, but due to the radiation risk, this option require thoughtful consideration, and the plain X-ray are the low cost, therefore they are useful to access infant and with low risk of the craniosynostosis, but it is not accurate enough, and MRI is less accurate when compared to CT, but it is still a great method to use, but usually reserved for children in which the CT revealed any anomaly of the brain. Ultrasound is a low-cost modality, but the technician dependent, that can only be used with the open fontanelle, but it is very useful to visualize and follow up the suture at every examination. Ultrasound is a low-cost modality, but technician dependent, and that can only be used with the, we can say, the open fontanelle, and but it is a very useful to visualize and follow up the suture at every examination. And the most accurate method is the CT scan, because showing the 3D reconstruction where all sutures are accessible, but due to the radiation risk, and this option require thoughtful consideration that the plain X-ray are low cost, therefore they are useful to assess the infant with low risk of the craniosynostosis, but it is not accurate enough, and MRI is a less accurate than compared to the CT, but it is still a great method to use, but usually reserved for children, in which the CT revealed any anomaly of the brain. And the new modality are now is used, like we can say the grace, gradient and spin echo, or that it is a type of MRI which enhance bone soft tissue boundaries and showing the cranial suture as hyperintense, and when encountered with the syndromic craniosynostosis, genetic testing is the useful follow-up and recommend mostly when two or more sutures are affected. Testing for the fibroblast growth factor receptor gene, which have been the gene most commonly related to this syndrome, which is called the FGFR2 and FGFR3, because these fibroblast growth factor receptor gene 2 and 3 undergo testing, as well as the transcription factors are also showing their results. So increasing level of research have taken place to understand and determine the genetic cause of the syndrome, and to date 57 genes have been identified to have a relationship and be underlying cause of the craniosynostosis, and the most common one being the, we can say, once mentioned above. Here I want to mention, you can appreciate these are the radiological picture. This is the classification of the craniosynostosis here, or the pansynostosis, or the you can appreciate here, and this X-ray, actually, as I mentioned, the CT scan is the most accurate method. The most accurate method is the CT scan with 3D reconstruction, where all sutures are accessible, but due to radiation risk, the option requires thoughtful consideration, and the plain X-ray we are using. This is the CT scan, the effectiveness of the CT scan I want to show here. And now definitely this is the X-ray, and it is the craniosynostosis patient. You can appreciate there is a bicoronal suture synostosis. So definitely these all modalities giving us very good, we can say very good information, but which modality we can use where, you should know better. Here you can appreciate both. The above two photographs are X-rays, and the below two photographs are CT scan, and you can appreciate how they are giving their information to us and how much in detail. And here we can find there is a you can unilateral coronal suture permanent closure, and you can appreciate how the face is look like on the CT scan. Now regarding the treatment management, the management of these patients depend on the kind of the craniosynostosis, what kind of craniosynostosis, and then that. So the management of these patients depend on the kind of the craniosynostosis, and the uncomplicated and we can say the non-syndromic type can be managed surgically, and but the elective, but the uncomplicated and non-syndromic type can be managed surgically, but electively compared to some syndromic form that require the urgent surgical intervention due to the involvement of the airway, ophthalmologic and the neurological system, and a conservative approach with the remodeling helmet should be attempted first in case in which the unilateral craniosynostosis is not to serve. And the excellent as well the type of surgery depend on the age and the presentation of the patient. So the two modalities are in use, and the endoscopic we can say the suturectomy done in patient less than 6 months of age, because the bone is more flexible and manageable by an endoscope, and the post operative recovery is faster. There is a less blood loss, and the surgery is shorter compared to the open craniotomy, and the only we can say the downside is that the most time that there is not to combine the surgery with the post-operative use of remodeling helmet for 4 to 6 months. So endoscopic suturectomy nowadays very popular, because in this the endoscope, that kind of endoscopes are available, and and we have that kind of instrument. They can cut the bone very efficiently and endoscopically. So as I mentioned, we have both options: endoscopic suturing, open craniotomy. But the management of these patients depend on the kind of craniosynostosis. So it is very important, because the uncomplicated and the syndromic type can be managed surgically, but electively, compared to some syndromic form that require the urgent surgical intervention due to the involvement of the airway, ophthalmological and neurological symptom. So the conservative approach with remodeling helmet could be attempted first in case in which unilateral craniosynostosis is not too severe, but the extent as well as the type of surgery depend upon the age and the presentation of the patient. I want to show you here something very important regarding. You can appreciate here in this picture, this is the endoscopic way of suturectomy, and here you can see there is I want to mention that you can appreciate how this endoscope has been introduced, and then the suturectomy has been done, and it is a semi endoscopic, you can appreciate, and here you can see the endoscope has been introduced, and these are the specific instrument, and it is from the very specialized center in the world for the craniosynostosis. And these are the post-operative CT scan. You can appreciate how the bone has been taken off surgically, and the suture, and let the heal for as a second chance, and then the significant improvement has been expected by these kind of procedures. Here you can appreciate the planning, and you can appreciate how sometimes we have to plan for correcting these kind of the craniosynostosis. This is you can say the geometric, or we can say the planning we are doing with this way, and the 5 centimeter you can say apart is a 2 centimeter apart, and the 1 centimeter apart. Actually all are working. It depends upon the patient and the expertise of the operating surgeon. What I did up till now, 1.5 centimeter, 2 centimeter, really giving a decent result. Patients are happy, families are happy. Definitely patients cannot be in that position. They can talk, definitely they are very much and means the pediatric age group is small child. So the children are means and definitely are getting good results with that, and I did few cases and I found good results. How we are giving the soft tissue incision in that, and the soft tissue incision you can appreciate here where there's mentioned very well, and you can understand this. The open craniotomy done in patient older than 6 months, because the bone are more rigid and cannot be manipulated as well with an endoscope. So this modality allows for a better remodeling of the skull and decrease the need for helmet use post-operatively. Endoscopic suturectomy actually, when this is the only downside in that in the most time, and this is the need to combine the surgery with the post-operative use of the remodeling helmet for 4 to 6 months. This is the only downside. And otherwise, in open craniectomy, you don't need to use or decrease need, we can say, of the helmet. And the main goal of the surgery is to create enough space in the cranial vault for the brain to grow and develop properly, as well as to provide the child with a more decent looking appearance. Definitely, we are doing the craniosynostosis for the lot of reasons, and one of the reason is that aesthetics, and the aesthetics should be appropriate in that regard. The family could appreciate some difference after that a significant surgery, because when we are dealing with the coronal suture, actually we are definitely we are over the superior sagittal sinus, and everybody knows that the superior sagittal sinus, anything near, when we are trying to do a surgery, then there is the great chance we can injure that superior sagittal sinus and other sinuses. So we will talk about that complications also. But I want to mention here that the positional plagiocephaly requires a differential from the craniosynostosis, and it has no premature fusion of the suture, and it present with the parallelogram of the head, ipsilateral anterior displacement of the ear and head, and ipsilateral occipital flattening, and the contralateral occipital boozing. So the prevalence has increased over time due to the back to the sleep campaign, and to reduce the incidence of the sudden infant and death syndrome. Still, the only concern is cosmetic, and it can be managed, we can say, supportively by alternate the side of the head on which the baby sleep. And the remodeling helmets are also an option, and the condition does not require the surgical intervention. It does not affect the neurological development, and the parents should be reassured, or we can say instructed to continue making the baby sleep on his back. And the prognosis, if left untreated, craniosynostosis can affect the development of the child, and this is due to the restriction for the growth of the brain and damage to the brain tissue due to increased intracranial pressure. And the degree of the developmental delay hints on the kind of craniosynostosis, and the children with the sagittal synostosis have a low risk of learning disability compared to those with the metopic, or we can say the unicoronal or the lambdoid synostosis. So with early identification of the developmental gap and the placement in the, we can support program, a negative academic or the cognitive outcome for these children should be reduced if not prevented. And when surgical intervention occur promptly, cases have an excellent outcome with relatively normal growth and development. So follow-up for the another fusion of the suture and the head growth is crucial to determine the need for the intervention in these patients, with particular focus on the syndromic craniosynostosis. Regarding the complications, as you know, when we are treating any patient, definitely they have some procedure, have some complications, and the surgical treatment can lead to several complications like the post-operative hyperthermia, infection, meningitis, seizure, subgaleal hematoma, subcutaneous hematoma, and cerebrospinal fluid leakage. So the risk of complication increase with intervention as well as with the open craniotomy compared to the endoscopic approach, where the complications are minimal. In case of severe blood loss, mortality and morbidity can reach up to 50%. If I say the deterrence and the patient's education, the occurrence of the syndromic craniosynostosis is only preventable with the genetic counseling. And as I mentioned regarding the prince, that her wife gave the birth for the two child, and both have the Pfeiffer syndrome, and she has a facial Pfeiffer-ish effects of syndrome, but her both children have the Pfeiffer syndrome, and they died early because of that rare genetical problem. And Pfeiffer syndrome is a kind of a syndromic craniosynostosis. That's why we are talking about it. So the craniosynostosis is a premature fusion of one or more suture, and is a common condition, as I mentioned before. So the most common non-syndromic craniosynostosis is by premature fusion of the sagittal suture. So we have to look for the sagittal suture, and we have to and in syndromic cases, the most commonly affected gene are, and as I mentioned, that the sagittal suture, when we are treating sagittal suture, then you know that then we have to be careful, because we are over the superior sagittal sinus. Definitely coronal suture also, but it is once you are crossing the superior sagittal sinus, then it's okay. But in the sagittal suture, superior sagittal sinus is definitely constant. We can say under manipulation. So in syndromic case, the most commonly affected gene are I want to mention here again, the fibroblast growth factor receptor gene, and the early surgical management between 6 to 12 months is a treatment of choice in syndromic craniosynostosis, and the positional plagiocephaly does not require surgical therapy. And the degree of the developmental delay is depend on the kind of the craniosynostosis. And the children with the sagittal synostosis have a lower risk of learning disability compared to those with the metopic, unicoronal, or the lambdoid synostosis. So with early identification of developmental gap or placement in the support program, a negative academic or the cognitive outcome for these children could be reduced if not prevented. And interprofessional approach to care is essential in the management of the patient. An interprofessional approach to care is essential in the management of the patient with craniosynostosis, especially those with the syndromic craniosynostosis, and the team should include the pediatric surgery, neurosurgery, pediatric neurosurgery, plastic surgery, maxillofacial surgery, ophthalmological surgeons, genetics doctor or specialists, nurses, respiratory sleep physicians, orthopedics, and later on the developmental specialists nowadays available to help such kind of patients. And they also require the physical therapy, occupational therapy, speech therapy, as well as the possible hearing or the vision aid and placement in appropriate school setting. And the follow-up is for the prolonged period, because if the infant grows, physical and the mental deficit may come to light with early identification, developmental gap, and placement in the support program, or a negative academic or the cognitive outcome for these children is minimized if not prevented. The lives of some children can be improved and some not. And I want to present here one case as an analogy, because always when I am presenting any lecture, I try to present of one of my case. The reason is that I want to correlate what the knowledge I am transferring to you people or trying to transfer to you people. Am I doing the same way or some other way? So here we go. And a new mother and a father are concerned about the shape of their baby's head, and they point out a flat area of the head on the left side and have many questions about the Craniosynostosis surgery, and which they read about on the internet, and they have already scheduled a consultation with the plastic surgeon next week and are concerned about the potential brain damage to their baby. Definitely, my the differential diagnosis was two. It could be the craniosynostosis or it could be the plagiocephaly. Actually, and I took one picture which is very much similar to my patient, and I want to show you here. Actually, I took this picture from the book because, and it is almost near or similar to my patient, and you can appreciate here. So the imaging description and differential on X-ray, skull, or the CT scan, as I mentioned, these two modalities are skull. The best modality is CT scan, but the X-ray is the modality in that regard to avoid too much radiological or the radiation exposure to the small patients or this pediatric patient. A thorough physical examination from the multiple angles of the patient head will allow one to recognize distinguished sign of the positional plagiocephaly from true craniosynostosis. In plagiocephaly, the flattened area, for example, the flat occipital flattening will have the ipsilateral left frontal prominence, and this can be noted by comparing the position of the ear and having the parent hold the child in a sitting position and the standing over the head, then the examiner can easily tell if the ear or the forehead are advanced on the ipsilateral side of the occipital flattening, and the head shape will assume the classic parallelogram appearance, and this is to be differentiated from the much rarer unilateral lambdoid suture craniosynostosis, so where the head shape assumes a trapezoid appearance. In difficult cases, a CT scan may be obtained to differentiate between the two entities. The position plagiocephaly is the most frequent secondary to the position, and the children had repetitively in the same location and using the skull to flatten out on one side, and given the pediatrician education with regarding to the prevention of the sudden infant death syndrome, babies are positioned in their back in some cases exclusively, and the flattening can be exacerbated by the neonatal torticollosis, so which will result in preferential head turning to one side if not corrected early by repositioning or physical therapy. In the case of the torticollis, clinical significant cranial deformity may occur. This is the plagiocephalic helmet, and I just wanted to show all of my audience, they can see and they can understand that what kind of the helmets has been used. It is called the plagiocephaly helmets, and people are using and the doctors are using, even though for the conservative treatment sometime, and sometime when they are doing the endoscopic suturectomy for the craniosynostosis, and sometime they are using with the open surgical repair, or we can say the correction of the craniosynostosis. So that's why I wanted to present or show this picture. This is one more example of the plagiocephalic helmets, and you should know this is the plagiocephalic helmets. You can see she is wearing the helmet, plagiocephalic helmet, because it needs for a longer period of time. This is an example of plagiocephalic helmet. Actually, you know that the deformational plagiocephaly, also known as the positional plagiocephaly, because I not remember did I explain the plagiocephaly in front of you people, but I want to explain it. And as you know that the plagiocephaly is a deformational plagiocephaly, and also known as positional plagiocephaly, means mishappen, or we can say flat, or we can say uneven, or we can say asymmetrical, or we can say the head shape plagiocephaly does not usually affect the development of the baby's brain, but if left untreated, it may change their physical appearance by causing an uneven growth of the face and the head. So, for those people, they are watching regarding from the what I want to say here, means as a patient, and it is also very much informative for doctors and for patients' information also. If children ask, for example, there is a more severe, if somebody asks just plagiocephaly, go away. So I will say more severe cases will also get better over time, although some flattening will usually remain, and the appearance of your child head should improve as they become more mobile and their hair grows, and it's very rare for a child to experience problems such as we can see the teasing when they reach to the school going. Plagiocephaly and brachycephaly, it is also called the flat head syndrome. And you know, if the plagiocephaly is untreated, and if congenital plagiocephaly is untreated, which is because of the craniosynostosis, that's why I want to mention both things. One is a positional, one is a congenital. So I forgot to mention earlier, but right now I am including it, and you are listening. I hope you will like it. So, which is caused by the craniosynostosis, and the left untreated can lead to serious complications, include the head deformity, possible severe and permanent increased pressure inside the head, and the seizures. And as you know, the plagiocephaly happens in adults also. So what are the causes to, actually they may be due to the positional molding and the less common conditions such as the craniosynostosis, where one or more suture in the skull fuse permanently. So it is regarding the, and how do we fix the plagiocephaly? Actually we have to practice tummy time and vary the position in the crib, or limit time in container, or limit the time of your child spending lying on the back or with the head and resting against a flat surface such as in car seat or the stroller or the swing or the bouncy seats. So these are very important information we have to pass to the family so they could understand. So now I'm coming back to the treatment options. What I did for my patient. Actually, all treatment are controversial, and as the efficacy of any intervention compared with the natural history of expectant management has not been definitely determined. So the repositioning, altering head position while sleeping on back, ideally minimizing back time while awake, and the physical therapy for the patient with the neonatal torticollis, and the cranial orthosis over, we can say, the 23 hours a day of the maximal effect for the total of 3 to 6 months. You know the unilateral coronal synostosis, which is also called the anterior plagiocephaly, and the lambdoid suture, which is called the posterior plagiocephaly. So, these are the congenital plagiocephaly, and there you can find the few sutures and flattening of the ipsilateral frontal bone and the bulging of the right squamous temporal bone and the bulging of the contralateral frontal bone. So the nasal radix deviated to be ipsilateral side and air ipsilateral to be fused suture and displays anteriorly. So the ipsilateral Herculean deformity seen on the radiograph, and this you can see the superior orbital ridge you can appreciate, which is also called the Herculean deformity, and the superior displays ipsilateral great wing of the sphenoid bone, shortening of the ipsilateral anterior cranial fossa, narrowed ipsilateral sphenopetrosal angle, and narrowing of the ipsilateral mediolateral diminish of the orbit. So we have to treat with the craniectomy of the fused sutures or the suturectomy associated with the craniectomy, and unilateral orbital and bar advancement. So you know that when we are treating the bilateral coronal suture brachycephaly is a little different from this, and when we are treating separately, we have to feature of the bilateral coronal synostosis in brachycephaly, fused coronal suture, or recessed superior orbital rim, prominent frontal bone boozing, flattening of the occiput, and the anterior displayed skull vertex. So the shortened and anterior cranial fossa, Herculean deformity of the greater wing of the sphenoid, and the protrusion of the squamous protrusion of the temporal bones are treated with the bilateral frontos superior orbital advancement here. So it is a very important to notice how we are addressing the issues here. As you know, the sagittal synostosis characterized, which is called the cephalocephaly, and which I mentioned in my lecture also, that the bitemporal narrowing and the ridging of the fused sagittal suture, this frontal boozing and the occipital boozing, a simple linear craniectomy of the suture can be used up to the 5 months of the age. It is a very, very much appropriate. And other is a lambdoid. For lambdoid, you are, for example, the unilateral lambdoid fusion and fusion, or the unilateral and fusion superior or posterior plagiocephaly, occipital flattening, and the anterior displayed air ipsilateral to fusion. So the bilateral lambdoid fusion with the bilateral occipital flattening and the prominence of the frontal bone and the elevation of the skull vertex. So these all are the finding, and you know that, and you have to address by that way. And you know, sometimes skull base changes is happening in the setting of the right posterior deformation, plagiocephaly, or positional modeling. So the parallelogram we have to parallelogram shaped head, anterior displacement of the right ear and the right frontal boozing. This is in contrast to the unilateral lambdoid synostosis, which is marked by trapezoid shaped skull. So the posterior displacement of the ipsilateral ear and contralateral occipital boozing, this is very important to know. You know, here usually you know the surgery is effective in younger infant between 4 to 8 months of old, and when they are their fasted cranial growth rate, the surgical intervention is reserved to extreme and refractory case of the positional plagiocephaly. For true synostosis, a strip craniectomy of an affected suture at 3 to 6 months is often sufficient, and surgery may be performed as early as 3 months if ICP is raised. If ICP is raised, we have to do in within 3 months. But people are telling 3 to 6 months is very good for the strip craniectomy, and effective in 4 to 8 months. And very few cases people operated later and they got the result. They have their own technique. They are reversing the craniate, means when they are placing the bone, they are reversing it. So multiple procedures have been used for unilateral lambdoid synostosis, from isolated strip and craniectomies to extensive total cranial with cranioplasty with the barrel stove craniotomy. So the following describe a limited cranioplasty with reversal and, or we can say, the rotation of the bone segments. Here, as I mentioned, the reversal or the rotation of the. I want to mention here. I want to show you here one. So that's how is doing. These are the bone pieces. We are molding these bones and then replacing it. And I did few of the cases, and I find, because I have a 5-year follow-up of them, and they are better than previous. And the pictures we have and we showed to the people. This is also a technique. This is also a technique, and you can see here. This is also a technique in this endoscopic sagittal synostosis repair. You can see how the bone has been removed, how much bone has been removed. This technique also applied, and a lot of people are applying. I am trying to put the picture which are not with the real blood or thing, because according to the YouTube policy we have to take care for that. So as I mentioned, we have to, as early as we can, operate 3 months if ICP is raised. But before 3 months, I think it is not an ideal. Or but the most of the patient which I treated was between the age 5 months and above usually. So the surgical technique, the multiple procedures have been used for the unilambdoid synostosis, from isolated strip craniotomies to extensive total cranial vault cranioplasties with barrel steep osteotomies, and the following describe a limited cranioplasties with the reversal and rotation of the brain segment. A patient is positioned prone in a horseshoe shape. I'm talking of the lambdoid. It in horseshoe shape, and ear-to-ear incision is made. Ear-to-ear incision has been made, and after infiltrating the scalp with the suitable local anesthetic agent, the posterior scalp is dissected in a subgaleal plane to minimize the blood loss, and the biparieto-occipital cranial monoblock flap is created with the high-speed craniotomy, with the high-speed craniotome. After placing the burr hole over the posterior sagittal sinus and on either side of the sagittal sinus, just proximal to the tropola, the great care must be taken when dissecting the cranium from the dura adjustment to these vascular sutures. So the posterior cranial flap is then remodeled, and often be by rotating the flap 180 degrees and replaced using an absorbable cranial plate fixation system. Cranial plate fixation system, it depends, has different ideas, have different people, but definitely we have to be careful when we are using it, because we have to allow the head size increase. Complication and avoidance and management of infection, post-operative drain, and pre-operative or perioperative antibiotic is very important. I must say the blood loss, meticulous surgical technique, and communication with the anesthesiologist. Leptomeningeal cyst, it happens sometime in the immediate repair of the underwent urotomy noted at the surgery. So I try to explain in detail what I was thinking. Definitely, I cannot fulfill all the thirst and the requirement of the knowledge of this topic, but definitely, if you like it, please support us, share, and support by any means.